Good afternoon, everyone. It has been a long day so far. This is my topic. However, it's not going to be what I'm going to talk about. Why is that? First of all, what happened and why did this topic arise and why it's being discussed so much? First of all, obesity is a disease, and it's now considered as such. Type 1 obesity is a disease by itself. It causes a low-grade chronic state of inflammation. It will lead to cancer. It will lead to liver cirrhosis, metabolic syndromes, whatever. We need to treat it. Patients who are obese, they have 27% increment in physician visits. They have 46% increment for insurance companies, and we have an 80% increased expenditure in the medication. So this is a new term. Obesity type 1 is a disease. What happened 30 years ago? Those were the first guidelines. 30 years ago, the experts gathered, and it was a guidelines based on expert opinion. It wasn't a scientific guideline. They stated a 35 BMI with morbid obesity, we go for bariatric. More than 40, we go for bariatric directly. This was 30 years ago. And we have been using the same guidelines since 30 years. This is really unacceptable. What happened now is that, especially in the past 2 years, the COVID has proved itself in the size of the meta-analysis, meta-analytic studies. We have tons of them. And what happens is that we have science now. And we no longer talk about bariatric surgery. We talk about metabolic bariatric surgery. It's metabolic surgery. And those are the points that I want to discuss through those guidelines. I don't want to talk about the guidelines. I'm sure most of us read them, but there are some really red flags in the guidelines that we need to take into consideration. So, 1991 standards discussed, BMI. BMI has tons of limitations, and we all know them. However, it's still the mark is accepted by all. And this is not new, in fact. This is from DSS-2 from 2016, I guess. And as I mentioned, the class 1 obesity is a disease, and the endocrinologists are indicating bariatric surgery for BMI more than 30 with comorbidities. So this is the first new guideline. It has been there since 2016. Now it's verified. A BMI of 30 with metabolic problems goes for a disease. For type 2 and more, we go for bariatric surgery directly. However, the more interesting point for us is the BMI the same for all populations? In fact, it's not. And especially for Arabs, as we can see, that the equivalent to a BMI 30 of whites is 26.5 for Arabs. So if we take the international guidelines and we consider the 30 BMI, for us Arabs, it will be 26.5 and not 30. The international guidelines consider the lower marker for South Asians and for Asians as 27.5 with metabolic disorders, and this is considered as a trigger for an MBS. I think this is something that we should all consider. We as an IFSO Lebanese chapter, we should investigate it. This is so as we can come out with our guidelines concerning this sphere. Just an idea to keep in mind. Age extremes. We had limitations at 70 and at 80. Well, no more. Should there be any upper chronological age limit? Age is just a number. If a patient is active, he has good living style, good health, we can't say that he's 70. Frailty is the most important factor. Of course, elderly people will have more complications. It's expected. However, the studies show that it's just at the level of the severe complications, whether at the Roux-en-Y or at the sleeve, it's just a 1% increment. However, the benefits and the profit from the bariatric or the MBS surgery that he will have will be massive, and that will really change his life. So, frailty and not age alone. And, again, is age just a number? Yes, it is. However, the younger the patient, he will benefit more from our MBS. The younger he is, he will lose more weight. And this takes us to this point. What is the lower limit for our MBS? For whom should we offer it? I used this poster for a purpose. This is a massive study, 2,500 cases, recently published December 2021. Those were done on children and adolescents. Some of the patients are 10 years old, and even there are studies talking about 5-year-olds and 6-year-olds having surgeries, having MBS surgeries, okay? The most impressive point is that constantly, the younger the patient is, the better he is expected to benefit from the MBS surgery. Moreover, at the level of growth, they were not affected, and their lifestyle massively improved. And this is the second guideline that changed. There is no more talking about upper and lower limits. Tanner stage, bone age, should not be considered a requirement for surgery. This is not my talking. This is not the IFSO. This is the Children and Adolescents American Academy of Pediatrics and SMBS. The major change is here. Children with moderate obesity, that's 100 to 119 percentile, class 1, MBS is not recommended. However, once we go above 120, that will be over here, we should consider MBS. Of course, the patients should be selected carefully. They should be followed up properly. But a child, and when I say a child, I'm talking about more than 5 years of age with more than 120 percentile for MBI, he should be considered for MBS. The fourth point is the bridging. The first two, I think most of us know them. I'm going to focus on the rest. The first one is concerning total joint arthroplasty. I really want to thank our team, Dr. Iman Yunus, Dr. Fatima Faqih for helping me in this. We took the guidelines, we searched all the articles used, and we tried to compare the guidelines with the literature that they were using. And in this point, significantly, there was some discrepancy. Based on the guidelines, they recommend, if we are going to go for a total joint arthroplasty, an MBS is recommended within 2 years of the surgery. However, the main studies, the meta-analytic studies that they were using, and it contained a total of 9 studies, around 39,000 patients, the conclusion was bariatric surgery did not reduce the short-term risks for superficial wound infection, for venous thromboembolism, and the long-term risks for dislocation, periprosthesis infection, as you can see, it did not reduce. Moreover, the only surgery to benefit from it was total knee arthroplasty, but not total hip arthroplasty. It was really amazing to see that, to compare that. The new recommendations talk about considering MBS for patients that are going to have total joint arthroplasty. It's preferable if you're going to do that. For knees, for hips, it won't make much change. I'm really sorry for this slide, but I needed to copy-paste as it is. For hernia, we all know that bridging is important. An MBS within a year or two before hernia really improves the quality. So it's a guideline, it's out there. Once we have huge hernias, ventral hernias, patients with morbid obesity, MBS is recommended. Those are done. Those are the interesting points. The transplant patients. I mentioned it in the first slide. Obesity is a disease. It creates a chronic state of inflammation. This inflammation leads to end organ damage and failure of transplants. What was surprising, especially at the level of the kidney transplants, that 40% of patients who weren't eligible for transplantation after receiving metabolic bariatric surgery were eligible for transplantation. Same for the lungs, but what is really surprising is the heart. In the past 2 or 3 years, when we checked the literature, there was tons of articles on this topic, and there was literally bombardment on this topic. Patients of left ventricular assisted device. We are talking about patients with ventricular failure. Those patients that have a non-functional heart, those patients that are granted for cardiac transplant. And if you see this nice blue line, explantation, we have approximately 5% to 10% of those patients were removed, had their left ventricular assistant device removed after they received the MBS. Having a bariatric surgery for a patient with a heart failure increases the opportunities for conducting a successful cardiac transplant, and this is a domain of major investigation currently. This is a 2022 Jan approximately. Cirrhosis and cancer. This are my last 2 topics. I won't be so much. I love this one. We all know about NASH. We all know about fatty liver. Dr. Bitar presented a case years ago, but this is NASH and fatty liver. We know that. What about compensated liver cirrhosis? What about non-compensated liver cirrhosis? We are talking about child A liver cirrhosis. Child A liver cirrhosis patient who have bariatric surgery, first of all, major adverse liver outcomes at around 10-year interval, we can see a major drop in complications. And non-cardiac as well. And type A child A liver cirrhosis can tolerate the surgery. This is really important. This is massive. We are talking about liver cirrhosis. We are talking about the red lines that we had. And in fact, in 2020, this is not new, this is really old, an AGA clinical practice update on bariatric surgery and cirrhosis expert review. They came out with the guidelines, and that's what they recommend. In patients with decompensated liver cirrhosis, already discussed, patients going for transplantation, they should have MBS in order to increase the success rate. However, if patients who have compensated liver cirrhosis with no signs of portal hypertension and alcohol avoidance, having an MBS improves their quality of life and can spare them a transplantation. This is also a point I really think we should all put an eye on it. This is my last slide. 30,318 patients. We are talking about cancer. We're not talking about anything else. We are talking about our nightmare. Cancer risk, and especially obesity-related cancers, esophageal, pancreatic, whatever. We have a 50% decrement in the incidence of CA and obesity-related cancers in patients who had MBS. And this is something to consider. My take-home message will be as follows. We have new guidelines. We can, as it's said over here, the Asian population can be offered an MBS at a BMI of 27.5. Personally, I think we should, as Arabs, as Lebanese, we should investigate that. We can offer a patient an MBS more than 35. We don't need comorbidities for that. As a long-term results already are approved. And as for children and elderly, we should properly select our patients. We can really make massive difference in their lives. Thank you so much. I hope everyone had a good day. Thanks so much.